This is part 2 of hip fractures for PAs. If you are a PA new to orthopedics or you are a PA student entering your orthopedics rotation, this talk is for you. In the last talk, we talked about when do we fix hip fractures or when do we replace them. By the end of this talk, I want you to be able to understand what type of implants do we use for hip fractures and when do we use them. So let's start by looking at a hip. Now, we talked about in the last talk about how there's a blood vessel at the base of the neck here. It's very important for feeding the femoral head. We're going to assume for the purpose of this talk that basocervical fractures are going to be treated like standard intertrocks. We would call these extracapsular. So what is actually going on with this blood vessel is that there's a hip capsule here that contains that blood supply. And so these extracapsular fractures are going to have a femoral head that's going to survive, so we are going to fix them. So extracapsular. And so we're going to include basocervical as an extracapsular fracture. Now again, this is an asterisk because some surgeons are opting to replace these. The other one is a standard intertroch enteric fracture, in which the fracture line goes from the greater troch to the lesser troch. And we're also going to include subtrochanteric fractures, so subtrochs. Now, all three of these are all treated the same way in the modern orthopedics world, and that is a nail. So let's draw the rest of this femur. It's going to look something like this, something like that. And the reason we call it a nail is because if you look at an old femoral nail, it literally looks like a nail you get from Home Depot. It's just this long, sharp nail. Now they make nails that match the anatomy of the femur. And so the first part goes into the canal like this. And there's a second part that goes into the head. So it's a screw device or a blade device, depending on what vendor you use. And since there is a component that goes into the head, we call it cephalo, and the component that goes in the medullary canal we call medullary, cephalo-medullary nail. So if you learn anything, extracapsular fractures, which include basocervicals, intertrochs, and subtrochs, all need cephalomedullary nails, and that's pretty much all you need to know. Now, what can be confusing sometimes is that a lot of hospitals, a lot of people use the trade names for these. For example, in my hospital, we use a lot of Stryker. The company Stryker makes a nail called a gamma nail. There's a company called Synthes that makes a TFN or a trochanteric fixation nail. There's a company called Smith & Nephew that makes something called the Intertin nail. These are like using an iPhone or a Samsung Galaxy, but really the generic name is a cephalomedullary nail. So that's what you're going to see in research papers and in textbooks. These come in two flavors. One is a short nail, which I drew here, and one is a long nail. Now a long nail looks just like a short nail, except this medullary component will go all the way down, spanning the entire femur. You're going to have one or two screws that go across the bottom. The main advantage of a short nail is that they're easier. They're faster, there's less blood loss, they're easier. The advantage of a long nail is that it offers more stability. So they're more stable, so when you have a more complex fracture, like a subtroch for example, you're more likely to use a long nail. The other advantage of a long nail is that you're protecting the entire femur. So if there's a piece of metal spanning your entire femur, if you should fall, you're less likely to fracture the distal part of the femur. So protects the femur. So that's the short and the long of it. I do want to bring up another older way we used to treat these extracapsular fractures, and that is something called a sliding hip screw. This will come into play later on when we talk about types of femoral neck fractures, and also as a bonus I'm going to talk about why we don't use these anymore, although some people use them, and why they don't work in certain extracapsular fractures. So if I had to draw another hip, look something like this. Now a sliding hip screw had a plate component on the side of the femur and a barrel. So it looked like this. And a screw would go across, and then inside that barrel would be a screw. And that screw would slide. So if there was a fracture here, that screw would slide back and let that fracture heal. Now, the advantage of a sliding hip screw, the advantage was that it wasn't very expensive. So these nails, these new fancy cephalomedullary nails were quite expensive, but they worked for unstable fractures. The sliding hip screws were cheap, but they would fail if the fracture was unstable. So historically, you had to determine, was this a stable intertroch or basicervical fracture, or was it unstable? If it was unstable, you could not use a sliding hip screw. Now, in general, any type of intertroch, subtroch, basicervical, we're going to use a cephalomedullary nail. To put this in perspective, I finished residency in 2018, and I've never seen a sliding hip screw placed for this type of fracture. So let's move on to the next part. As a bonus at the end of this talk, I'm going to talk about in details what makes an intertroch stable versus not stable, but that's probably beyond the scope of what you need to know right now. So let's move on to the other type of hip fractures that we fix, namely the femoral neck fractures that are non-displaced or minimally displaced. So let's draw another femoral neck or femur. Now, we talked about how the blood supply to the femoral head is along the base of this neck, and it's going to give these arteries into the head. And we also talked about how this line kind of demarcates the capsule of the hip. And so if you fracture inside the capsule along the neck, what we'd call a transcervical femoral neck fracture, or even one that's right below the head, or a subcapital, we call these intracapsular fractures. And as long as they're minimally displaced or non-displaced, we usually try to fix them. So we're going to call this femoral neck. So either non-displaced, or if you remember, the minimally displaced, the most common one is valgus impacted. Again, I'll put this with an asterisk. Some people are more apt to replace even the valgus impacted ones because there's some data to suggest that they have a better functional outcome. And if these don't heal, so say you put the screws in and the head does not make it, well, then you have to go back in and do a hip replacement later, and the outcomes are not as good. So some people argue you should actually just go straight to arthroplasty for those. For the purpose of this talk, the majority of people are still fixing these, so we'll treat non-displaced femoral neck fractures as an intracapsular fracture that you're going to fix. And the way we fix them most commonly is 3 screws. So 3 screws that go, one on the inferior part of the neck that goes here, and there's 2 superior ones. So one goes here and one goes right alongside it. They're parallel screws, so 3 parallel screws. And if you look at it from another view, if you look at it from a side view or a lateral view, something like this, and this would be kind of like the greater troch, and this is the femur. And so this would be the anterior, and this is posterior. If you look at this from another angle, this inferior screw here, on that view, on the lateral view, it's going to go right down the middle. So you're going to start the screw here, and it's going to go into the center part of the head. The 2 superior screws, these 2 are actually going to be spaced out wider. So anterior and posterior, you're going to place these on either side of the head. Now, if you look at the alignment of these 3 screws, it's a triangle with the point pointed down, and we refer to this as an inverted triangle. Now, how we put these screws in, we can actually put them in percutaneously. So you can actually do this through a rather small incision. You make a small incision on the skin. You don't have to do an open reduction. You don't have to open up this whole hip to do the surgery. What we do is we will put long pins into the head like this. And if we like it, if we like where it all lines up, then we will take a screw. Now, a standard screw is solid, as in it's not hollow. It's just a screw with threads. Now, they make screws that are hollow. There's a canal they make in them. So it looks something like this. And this canal, or cannulated screw, allows us to put this screw over these pins, and we drive those screws into the head. So the official name for this surgery is percutaneous, since we're going through a small percutaneous incision. This is not an open reduction per se, it's percutaneous. Cannulated screw, because we're going over these pins, percutaneous, cannulated screw fixation. So that's a mouthful. So some people say perc screws, and most commonly we say hip pinning, because the first step is pinning them, and it's just easier to call posting and say I want a hip pinning rather than I need a percutaneous cannulated screw fixation. So most of the time for these femoral neck fractures, we're going to treat them with 3 parallel screws in this inverted triangle. Now you need to know about one particular type of femoral neck fracture. What an old resident used to tell me was the snake in the grass. So for a femoral neck fracture, you should always look for this. Now when we drew these other fractures, if you measured this angle from this line to that angle, that angle that we drew, say that was a fracture line, say on average it's like 45 degrees. What if the fracture line went in a different direction? What if the fracture line went more straight up and down like this? So instead of being like 45 degrees, that angle is greater than 70 degrees. Say it's 80 degrees or so. All this is a different scenario. So we would call this a vertical femoral neck fracture, or there's a classification for this type of fracture called the Powell's classification. And this is a Powell's 3, which is the worst one. And since this is a vertical fracture, if someone puts weight on this, it's more likely to fail. There's more stress going through those screws if you do the standard parallel 3 screws. It's important, if you notice this, that the surgeon knows it is a vertical fracture, because the surgeon will need to have different implants in the room, including the sliding hip screw. So some people will fix these with a sliding hip screw. You put the sliding hip screw and the screw goes in the head, and you follow that up with another screw to keep it more stable. Another way to fix this is to put the screws in different angles. But when you see a femoral neck fracture that's non-displaced, make sure you're looking for this Powell's 3 vertical hip fracture. So that is it in a nutshell. If it is a extracapsular fracture, we're going to be using a cephalomedullary nail. If it is an intracapsular fracture, femoral neck fracture that's non-displaced or valgus impacted, we're going to use these percutaneous cannulated screws or perc screws or hip pinnings, unless it's a vertical Powell's 3 fracture. That's it for this talk. That's all you really need to know. If you want the bonus content, the A+ student content, keep watching. We're going to talk about stable and unstable intertroch fractures. And the reason this is relevant in the post-sliding hip screw area of hip fractures is that for unstable fractures, a lot of surgeons are more likely to use a long nail. So a long nail. So we know for these extracapsular fractures or peritrochanteric fractures, we're going to use cephalomedullary nails. So there's 2 parts you need to look at when determining is this stable or unstable. The first is this cortex, what's called the lateral cortex. So there's a little bump where the greater trochanter is, and just beyond that bump starts the lateral cortex. The other part of anatomy we need to see is this part called the calcar. So we're going to call this lateral cortex. We're going to call this the calcar, also referred to as the posterior medial cortex. Now, standard intertroch fracture is going to go from the greater troch to the lesser troch. What if instead of the fracture exiting out the greater troch, it exited out this way? There's actually a name for this, which actually I didn't learn while I was training, but I learned since then. It's called trans-trochanteric. It's not intertroch, it's through the trochanters. Trans-trochanteric. If you bring that line even further, so that if this is an oblique fracture, if you reverse the obliquity of it, we call this a reverse obliquity. And the other way to breach this lateral cortex is a fracture that is below the lesser troch, so a subtroch. Now, a subtroch is a special case for unstable fractures because there are more forces at work that's going to make this a more challenging case. These are all very, very unstable because of this lateral cortex idea. Now, the other reason this would be unstable is if this posterior medial cortex or the calcar is unstable. Now, you can use the lesser troch as a corollary for this, but just because the lesser troch is fractured doesn't mean it's unstable. Now, if you see a large lesser troch fracture, that would be cause for concern, or if this calcar is comminuted, that would be suggesting this is very unstable. And the reason you need to notice this is if you can tell the surgeon this is a subtroch fracture, this is a reverse obliquity fracture, or it's a very comminuted unstable intertroch fracture where they in their mind are going to mentally prepare for maybe using a long nail or even having other options available. Well, if this is helpful, let me know. Send me an email, put a comment. If there's anything else you want to learn, I'm happy to make more videos if they are helpful for your education.